Greetings and welcome. Thank you for joining us today. My name is Sudha Shivaram. I am a program director with the NCI Center for Global Health. In 2021, in commemoration of the Center for Global Health's 10th anniversary, we launched this new NCI Global Cancer Research and Control Seminar Series. In this series, we feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I'm very happy to welcome Dr. Nirmala Bhoo Pathy, Associate Professor of Epidemiology in the Faculty of Medicine, University of Malaya. Dr. Bhoo Pathy practices as a public health physician with the Universiti Malaya Medical Centre, Malaysia, and is a visiting scholar at Queen's University, Belfast in the United Kingdom since 2014. Dr. Bhoo Pathy's career is focused on optimizing life after cancer in resource-limited settings through research and advocacy. She's particularly interested in the state of cancer control in low and middle-income countries and in enhancing treatment outcomes and patient-centered outcomes in these settings. Notably, Dr. Bhoo Pathy was the principal investigator of Phase 3 of the Association of Southeast Asian Nations, ASEAN, Costs in Oncology or Action Study, comprising close to 10,000 cancer patients from 8 low and middle-income member countries of the ASEAN. The study has been crucial in providing country-specific evidence for Southeast Asian nations to prioritize policies and develop local solutions to reduce the financial loss and premature deaths associated with cancer. Dr. Bhoo Pathy currently serves on 2 Lancet commissions, namely the Lancet Commission on Women and Cancer and the Lancet Commission on Cancer and Health Systems. She's a member of the COVID-19 and Cancer Task Force in addition, which is a globally representative groups of cancer leaders who are gravely concerned that decisions made under the duress of the pandemic will have momentous consequences for cancer mortality for years to come. Nirmala graduated as a medical doctor from the University of Malaya, Malaysia in 2001. Following completion of her master's degree in public health with distinction in 2008, she was awarded a fellowship by the European Commission, under which she completed a master's degree in clinical epidemiology, followed by a PhD in cancer epidemiology from the University of Utrecht in the Netherlands in 2011. As a note, today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth, global health one word. You can find information about future presentations on our site and by following us on Twitter at NCI Global Health. If you have any questions and comments as you listen to the presentation today, please place them in the chat and we will take them after Dr. Bhoo Pathy makes her presentation. And now over to you, Nirmala, and we look forward to the conversation.
Oh, good day, everyone. I would like to say good morning, good afternoon, and good evening. It's night here in Malaysia. And thank you, Sudha. That was a very mouthful, very long introduction. I'm sorry I had to make you talk so long. And by the way, I would like to first, before even starting, it's an honor to be here. I'm very thankful, and I would like to say thanks to NCI Global Health for giving me this opportunity. So this is more like me sharing my experiences and what I've been up to in the past 10 years. So I note that NCI Global Health is 10-year-old, and it's been 10 years since we initiated the action study that we are talking about. And I'm going to just share our experiences, what we have been doing in the past 10 years. So with that, allow me to share my screen. And please let me know if my screen is up and you all can see my screen now.
Yes, we can, if you can put, yeah, now it's on presentation mode. Fantastic.
Yeah.
Thank you.
Okay. So the topic that I would like to touch upon is looking at financial toxicity following cancer in the low and middle income countries. So I've given a very general topic, but actually what I'm planning to do, I'm being cheeky and just picking up examples from Southeast Asia. And I think that is a very good representation because we have 2 upper middle income countries and we have several lower middle income countries and low income countries in Southeast Asia, which makes it easy. And I hope that whatever we share today will be useful for everyone, for colleagues from all around the globe. With that, what is financial toxicity? So when we talk to the physicians, they love the term. It's a new term, but when I talk to my colleagues who have economics or health economics background, they do not like the term financial toxicity because for what it is, there is currently no standard definition. And financial toxicity there has been attempts to define it. And the simplest and shortest definition that I could find is financial toxicity is the possible outcome of perceived subjective financial distress, which results from objective financial burden. So some may find this very hard to comprehend. So I think the next closest or the simplest way of expressing financial toxicity then is it reflects the detrimental effects of direct and indirect causes of cancer on the well-being of patients themselves, their families, and society. I think that's something which is easier to comprehend. And okay, so I got afraid a bit because my slide wouldn't move. Okay, so when we look at financial toxicity, there's no clear, like what encompasses that. So it has been proposed that there are several components in financial toxicity if you were to examine them in patients. And first and foremost, we are looking at objective financial burden arising from diagnosis of cancer. And here it's pretty straightforward. When we have active financial spending, for instance, we look at percentage of health-related spending that families make in relation to their annual household income. Or then we can even look at material responses. Is there a change in income? Is there a need to find second job? Is there a need to sell property because of the diagnosis of cancer, borrowing money, using savings, or missing payments? So this is the material response. Apart from that, financial toxicity can also mean that the diagnosis has brought and the ensuing financial hardship has resulted in psychosocial damages to the affected individuals and the families. These include changes in motivation, changes in quality of life, productivity, and there's some element of support seeking. For instance, the affected patients start searching for financial assistance. And is there coping care? Is there a change in the care plan? This can be deemed as financial toxicity as well. And last but not least, change in one's lifestyle or coping lifestyle, where people have to give up leisure activities, for instance, as a result of the financial burden from cancer. So from what I've shown now, we can see that financial toxicity is not just one particular outcome, but it's a group of outcomes that affect patients and their families. So now I would like to move on to action study. I know Sudha briefly introduced me and cited the action study. So this is a prospective longitudinal study, and it was a collaborative effort with George Institute in Australia and with all the principal investigators from the 8 low and middle income countries in Southeast Asia. We got together and started this study. And at that point of time, there was really paucity of health economic evaluations which were conducted from the patient's perspective. So traditionally, when we looked at health economics or health outcomes or health spendings, we were always looking at the payers or providers' perspective, and patients' perspective were not really given center stage. And only in the last decade or so, we started realizing that cancer is also costly for patients and their families, and therefore we need to start developing tools to measure them and see how they affect patients' clinical outcomes, quality of life, and future prospects, not only for the patients and their families. And it was thought that when we start looking from the patient's point of view and the knowledge that is gained from looking at the adverse economic outcomes and looking at things like drivers of cost, it will gauge the way to develop policy decisions and planning of interventions to avert that cascade of economic fallouts that happen to families after cancer. So with that, the ASEAN Cost and Oncology Study, or the short name is Action Study, is a longitudinal cohort study. We had close to 10,000 patients, and they were all newly diagnosed and recruited between 2012 and 2014. So the study was concepted 10 years ago. And we have 8 member countries who participated. I will show the countries in a bit. And we recruited from 47 public and private hospitals and cancer centers. And participants were followed up through the first year after their cancer diagnosis at 3 time points. And the main study tools that we used were interviewer administered questionnaires. We had a suite of questionnaires. But more importantly, we used cost diaries to capture the household level income and all the out-of-pocket expenditures that they had made over the 12 months. And this was made throughout for patients at a household level and not at an individual level. That's why we said that, action study was like more family orientated, if I can say that. And the countries involved and the sample size. So we had Indonesia, Vietnam, Myanmar, Philippines, Cambodia, and Laos, which were all lower middle income countries. And we had 2 upper middle income countries, which is Malaysia and Thailand. We had a good mix of male and female participants. The mean age was 52 years old. We had a public and private mix, but most of our patients came from public hospitals. And as I mentioned, there was 3 time point where we contacted patients and got them, sat with them and interviewed them and reviewed their cost diaries. And at 3 months, we had patients who passed off and lost to follow-up. And as a result, at 12-month follow-up, we had complete data for about 75% of patients. So that was about 6,787 patients whom we knew what happened to them at the end of 12 months. And this was not an easy task at all. It was, in fact, very difficult because we had patients who were ill, who were given cost diaries, and we just needed to stay in touch with them and make sure that they filled up their cost diaries. So this was one of a lifetime sort of research that I'm proud to be part of, because I don't think it's not easy to do this again. That's how it is, the action study. So when we talk about the study outcomes, we looked at the main outcome, which is financial catastrophe, which we defined as when the families incurred payments from their out of their own pocket that not reimbursed by insurance or employers, and that out-of-pocket payment exceeded a catastrophic threshold, and we set 30% of the annual household income as the catastrophic threshold in this study. So, and this was measured using cost diaries and household income data. Apart from catastrophic expenditures, we also looked at poverty, medical impoverishment, hardship, the coping strategies, and also the health-related quality of life. So we had actually put in a lot of other outcomes, which we also subsequently went on to analyze. But here we are only going to share what the main study outcomes and the discussions. So at the end of the year, what we found was that 30% of patients had died, and 48% of families had incurred catastrophic expenditures, and only 23% of patients were alive and the families did not experience catastrophic expenditures. And we also wanted to look at the cost drivers. So when we examined that, we realized that just by paying for medical costs, which means inpatient, outpatient care, purchase of drugs, medical aids, equipments, and so on, 37% of households were incurring catastrophic expenditures. This kind of indicated that the main cost driver in the region was payment for medical costs. And this is not inclusive of things like childcare and transportation and so on. So that was the key finding from action study. We also looked at factors associated with catastrophic expenditures and deaths. We allowed both these outcomes to compete, meaning that if a patient had died, we assumed that they did not incur catastrophic expenditure. That was an assumption that we made, which may not necessarily be true. But we allowed this to happen. And at 12 months, what we found is one of the biggest contributors for financial catastrophe or death is late stage diagnosis. And of course, lack of health insurance. And of course, all the other socioeconomic characteristics. For instance, patients who were from low-income families, those who had no paid work, or people who were already reporting economic hardship, meaning that even at baseline, at the point of diagnosis, they were already reporting inability to pay household bills and so on. These were the people who were at the highest risk of making catastrophic expenditures and also dying. So this was something that we showed through the regional study. But apart from analyzing the data as a whole, we also thought that it would be useful to look at individual countries. So among the first things that we wanted to look at, like things that we could act upon: health insurance, treatment, cancer stage. So when we compared these factors, what was the relative contribution of health insurance, stage, and treatment explaining these adverse outcomes in our patients? In all countries, cancer stage was the biggest contributor for catastrophic expenditures. And this was followed by treatment in some instances, and health insurance was marginal in most places. So this was something that we took as, because we always think that, it's the cost of the drugs, but more importantly, before even talking about the cost of the drugs, this shows that we have to look at cancer stage and try to see how we can get people to present earlier or get diagnosed earlier. And that may actually improve economic outcomes, and of course, eventually also affect the mortality and survival rates. So this is one of it. And of course, we had to compare between countries just as a benchmarking effort. And there were a lot of variations. So of course, in Thailand, we saw that the risk of catastrophic expenditures was about 25%. And Malaysia, at that time, we ranked according to the GDP. Malaysia has got a higher GDP compared to Thailand. And we were surprised to see that the incidence of catastrophic expenditures was close to 50% in Malaysia and almost 70% in Vietnam. And while the whole finding was something that took us by surprise, I think we were somewhat more surprised that even in countries which have supposedly achieved progressive universalism, meaning that we have universal health coverage, where in Malaysia and Thailand, and yet we saw quite high, and the risk of catastrophic expenditures were substantially high. And being a Malaysian and the investigators from Malaysia, we were also taken aback that Malaysia, the risk of catastrophic expenditure in the Malaysian patients were higher than Thailand. And we started thinking about, is it our health financing mechanism? Are we looking at our weaknesses? Why is the risk of catastrophic expenditure higher in Malaysia compared to Thailand? So the issue is that the health financing mechanism in both these countries are different, although both have achieved universal health coverage. In Thailand, they have a national health insurance schemes, and patients can access care also from the cancer care, also from the private hospitals. And in Malaysia, we have a dual public-private healthcare system. So these are two parallel healthcare systems that run in Malaysia. On the public side, we have the public hospitals, the Ministry of Health hospitals, university and army hospitals as well. And here, it's funded through general taxation from the public. And there's minimal fee for all citizens, irrespective of whether they have insurance or not. If someone is ill, rich or poor, they can get a highly subsidized care from the public sector, but with some limitations there. And in the private, it's predominantly for profit and funded by out-of-pocket payments and private or voluntary health insurance, and to some extent, government-mandated savings. So in Malaysia, we were keen to, examine further, why did we find very high out-of-pocket expenditures leading to financial catastrophe? So we went on to look at the Malaysian scenario specifically, and also because we were very eager to find out what are the cost drivers in our setting. So in Malaysia, we had 1,662 participants, and at 12 months, about 1,300 completed the cost diaries, and they were alive. So we only looked at survivors when we analyzed the Malaysian data. And a vast majority of patients were from Ministry of Health or public university hospitals. And less than 10% of our participants were from private hospitals. And when we looked at the incidence of financial catastrophe, what we noticed is that 51% of families at the end of 1 year had made catastrophic expenditures where they had spent more than 30% of their annual household income for cancer-related expenditures. But when we started looking at the different types of hospital, we started seeing that there were differences. For instance, in the Ministry of Health, about 1/3 of patients had incurred catastrophic expenditures as compared to the public academic hospital where about 2/3 of patients and their households had financial catastrophe. And as expected, in the private hospital, the catastrophic expenditures were pretty high. But this was just at the phase. We were more interested in the cost drivers. What drove this cost? What drove families into making catastrophic expenditures? So when we analyzed by hospitals, we started noticing that payments for medical care alone, which is in the pink bar here, accounted for very little of those catastrophic expenditures in Ministry of Health. Only less than 5% of patients or their families were making catastrophic expenditures because they were spending on medical expenditures. As compared to the University Hospital, which is also a public hospital, where 25% of families were pushed into making catastrophic expenditures because of medical costs. And in private hospital, 2/3 of patients also were pushed into making catastrophic expenditures because of medical costs. And this is expected because this is not subsidized at all. And we also looked at incremental contribution of traditional medicine. And we didn't see much of a difference in other places except in Ministry of Health, where we see that there's a doubling of catastrophic incidence of financial catastrophe when we included traditional medicine. But what was very obvious that we saw here is that in the public hospitals, the moment that we started including the non-medical costs, that's when the incidence of financial catastrophe just went up. In Ministry of Health Hospital, you can see that from 10%, when we added the non-medical costs, then the cost drivers, the catastrophic expenditure was very obvious. Also in the University Hospital, but less so in the private hospitals. So this was something that helped us understand, because earlier we were looking at the Malaysian risk of catastrophic expenditures and comparing it with Thailand, and we said, what's happening? Is it our health financing system? But when we started looking at the cost drivers, we realized that non-medical costs were important cost drivers when it comes to countries like Malaysia, where there is universal health coverage. And we think that this is something that is translatable to other countries with universal health coverage alone. So having just giving access to medical care may not be enough for people with cancer. And in Malaysia, we also tried to look at the predictors of catastrophic expenditures. So just like in the regional finding, we found that income was an important variable. But the type of recruiting hospital was also important, where the public university hospitals and private hospitals, it was found that patients from these settings were more likely to make catastrophic expenditures. And it's just got to do with the fact that the subsidized care in Ministry of Health in Malaysia, the hospitals, is pretty high compared even to the university hospitals. And this may explain why they had relatively lower risk of catastrophic expenditures. And private health insurance, again, was associated with lower risk of financial catastrophe. We did not find any influence of stage, but that was because probably we also had a lot of patients where the stages were unknown. And because of that, we found that those who did not get chemotherapy were less likely to suffer catastrophic expenditures. And this may have got to do with residual confounding from the stage that was missing for a lot of patients. So apart from looking at catastrophic expenditures, because if we think about it, spending above a certain threshold does not really mean the same thing for people from different backgrounds. The poor patients, for instance, spending 30% of their annual household income might mean a lot of things compared to a person who hails from a higher income bracket where spending more than 30% of their household income does not impact their daily lives. And for this reason, we also wanted to look at the economic impact of cancer on daily living. And in Malaysia, we could see that there was a lot of coping care and people giving up things, essential things in their daily lives. For instance, about 45% of patients could not pay for medicine, 20% did not end up buying their cancer drugs, and about 23% could not pay the rent or mortgages, and about 10% of patients couldn't even pay their electric or phone bills, could not pay for transport or meals or their fees for their school children. And many of them asked for financial assistance from family and friends. They also asked for financial assistance from legal sources, from banks and so on. Some had to use savings that they set aside for other use. So this was something that we could relate when we talk to patients, like instead of just saying that you spend a certain amount from your income, these are things that we were using to, advocate and tell how cancer really affects daily living in those who are living in Malaysia, for instance. But so I have covered what we did in the regional level and so on, and how we moved on to look at the Malaysian case scenario. And we noted that in Malaysia, the financial catastrophe was high despite us having universal health coverage. And also that one of the important observations was that non-medical costs like transportation and childcare, these were important things and they were drivers of costs and often go unnoticed. But action study has its limitations. We lacked finer details on the various types of costs. So for instance, we didn't know what exactly, we only knew the category, and it was very difficult to get very detailed data from the cost diaries. And we also had very limited data on private health insurance. And why I'm bringing it up, in countries, in the low and middle income countries, private health insurance is an important source of healthcare financing. So, and we couldn't really look at that using the action study. And we didn't have any information on indirect costs of cancer. What did cancer lead to in terms of employment, productivity? That was not something that we could, get information from the action study. So we went on to, in the coming years, after we finished the action study, we decided that we need more data. So we started in Malaysia first, and we went on doing these qualitative inquiries. And we gathered patients with colorectal, breast, prostate, and cervical cancer. And these are the cancers that we focused on, namely because they are the common cancers in Malaysia. And we recruited participants who were at least 1 year, diagnosed at least 1 year prior to the study. And we talked to a lot of patients. We had up to 20 focus group discussions. We included more than 100 patients. And these focus group discussions just happened right before the pandemic between 2018 and 2019. And we ensured that we captured patients from different sex, ethnicity, age, and time since diagnosis, cancer stage, and also, of course, the type of hospitals, because we have this dual healthcare system. So we had to ensure that we look at patients coming from both side of the healthcare. And we wanted to look at the cost drivers of cancer. And as expected, a lot of our patients said that cancer therapies and imaging services were important cost drivers. They made them spend out of pocket quite excessively, especially on innovative drugs. But it's not only innovative drugs, even standard regimens of chemotherapy, because the nature of the therapy that they have to come often, and also imaging services. And a lot of them, what they told us was that it's not a one-time cost, and there's a need to have a long-term therapy. And this is often something that is missed. It's not just the 12 months after cancer, but patients may need very, very long periods of treatment, and that can be very costly. And the other thing that patients spoke, that was a very common theme that everybody spoke about, is on supportive care and medical aids, which tend not to be covered or subsidized under the public healthcare system. And at the same time, it's also not something that is reimbursed by private insurance. So this was something which was causing distress for patients. And apart from that, non-medical costs, for instance, like personal care items, hospital transportation, and childcare, household help. These are also things that are often not talked about. And we are always focusing on cancer therapies and how costly they are, but non-medical costs are important cost drivers. And one of the important things that we uncovered is a lot of patients spend on traditional and complementary medicine. So Malaysia is a multi-ethnic country, and there's this belief in traditional and complementary medicine is deeply embedded in the culture. So even when in instances when patients do not know the benefits, they just have this feel that they need to try, and because they have the social pressure and so on, and many end up spending on traditional and complementary medicine. And this is a very big mix there, a very big pot with you have things like homeopathy, body-based therapies, herbal therapies, traditional Chinese medicine, traditional Malay medicine. So it's a very, very diverse group of therapies here that we are talking about. But more importantly, across all cancer types, cancer stages, rich and poor patients, what was repeatedly highlighted is the indirect cost of cancer. So patients were, most of the time, they were fairly okay, doing well when they had their income coming in. But the moment that the cancer led them to lose productivity, or also in our instances where the employment protection is lacking, they also experienced pay cuts. Some of them lost their jobs or were forced to resign. And that's when it hit them hard, because now they were stuck in a situation where they have all these medical bills to take care and no income, or there's a reduced income. And this did not only affect the patients, but also their caregivers, who also had to take time off and spend time caring for the patients. So this was something that was brought up by almost every single patient who were employed in our study. And we also gathered from all our discussions and in-depth interviews with patients that the unmet financial needs are really this long-term need for cancer therapies. The long-term was something that patients keep on telling us about. And the limited private health insurance coverage was a big cause of distress for many patients. They felt that the reimbursement policies were suboptimal. And we also noted underinsurance and poor insurance literacy, even among the highly educated patients. And like I alluded earlier, traditional and complementary medicine, non-medical costs. And many said that there's a lack of assistance in dealing with this loss of employment or earnings. There was no one to go to. And the complex system to obtain financial support was overwhelming for most of them. They just gave up because there was just too much paperwork and so on. And patients were also in debt and they didn't know what to do. So it appeared that from our qualitative inquiries, there was a disconnect between patients and financial resources. We do have financial resources available, and this does not mean just, like financial aid and NGOs giving out monies, but we are talking about debt management agencies, and we are talking about financial planners and so on. We have them available, but patients are often unaware of the program, or they don't know what are the eligibility requirements. And of course, they complain of tedious paperwork. And on our side, the healthcare professionals are often unaware of this whole picture, or we are too busy to discuss financial matters with patients. And we do have patient navigation in some settings in Malaysia, but the scope is pretty limited. So there's no room to talk much about finances and how to improve financial status in patients. And going back to complementary medicine, we had some data from action study. So like I showed earlier, we did look at the incremental contribution of complementary medicine when you add the expenditures and what happens to level of catastrophic expenditures. But then when we started noticing that even during our qualitative inquiries that patients keep on talking about complementary medicine and how they need to spend, and we realized that, there is this, even though whether the doctors or the physicians like it or not, patients deem complementary medicine as an integral part of their cancer journey. And so we were interested to know what are the out-of-pocket spending patterns on complementary medicine, especially in a multi-ethnic setting like Malaysia. And we also wanted to know whether that out-of-pocket spending for complementary medicine, does it lead to adverse financial outcomes? And then we said, hey, we have got the action data, why not we examine that? And we started with Malaysia. So in Malaysia, we wanted to look at the spending patterns on complementary medicine following cancer. So we undertook a secondary data analysis of the action cohort. So here we had 1,249 cancer survivors who returned their cost diaries. We had their household income data. So we were able to collect, to analyze that, to look at the complementary medicine expenditures. And it was noted that out of that cohort, about 1/3 of participants reported spending out of pocket for complementary therapies. And when we try to quantify that, it was noted that the annual out-of-pocket expenditure. So I would just like to say that this interpretation may not hold currently, because this is data from pre-pandemic expenditures, and maybe it may not be the same presently. But nonetheless, I think this is something which is very valuable, because we have very little such data available. So we had annual out-of-pocket expenditure on complementary medicine was about $655. That was the median. And it ranged from 327 to $1,150 in patients. And what does this mean? You know, just looking at absolute, how do we put it in context? So what it meant was this amount was 35% of the health expenditures that families made out of pocket. So Malaysian households with cancer spend about 35% of their health expenditures on complementary medicine. That's what we found. And when we looked at total overall out-of-pocket expenditures, the expenditures on complementary medicine made about 1/5 of the total out-of-pocket expenditures that families with cancer made in 12 months following cancer diagnosis. So that was something that we thought, wow, that is a lot. So again, it reinforced that, you know, patients were spending on complementary medicine, whether we like it, we endorse it or not. And we also had some patients, about 200 of them, where we could dive deeper and see what sort of complementary medicine they were spending on and how much. So what we found is that patients from the action study spent about $2,000 on supplements. But this is data only from 200 patients, so it may not entirely be representative of all Malaysians, but that is a staggering figure for us. So that was on supplements. And what about on traditional local medicine, something which is also commonly used? About close to $1,000 was spent on traditional local medicine. So this was something that was a secondary outcome that we looked at when we analyzed the action data set. And we also wanted to see whether these expenditures increase the risk of adverse financial outcomes like catastrophic expenditures. And of course, yes. So in the overall cohort, we found that making expenditures out of pocket for complementary medicine indeed increased the risk of catastrophic expenditures. And this was worse in the subgroups which were financially vulnerable. So those who are from the low income group, when among this population, when they spend out of pocket for complementary medicine, they were more than double the risk of incurring catastrophic expenditures. And so were those who were already in hardship when they were diagnosed. And of course, patients were not employed. So one of the things that I wanted to, like a highlight here is when we looked at the expenditures that were made between a family declaring economic hardship at baseline when they were diagnosed and compared to another family which is relatively solvent, the expenditure was, about $687. And on the other hand, about $656, which were about the same. So whether the family had economic hardship or not, they were spending out of pocket on complementary medicine just as much as their counterparts who were financially solvent. So this was something that we realized that we have to pay attention to expenditures and complementary medicine, and it is not something to be ignored. But we did not find that expenditures on out-of-pocket expenditures on complementary medicine led to economic hardship, but that's only in the first year. It may be that the economic hardship or the inability to pay bills and seeking to cope happened in the years following that, which we did not capture in the action study. So because our data set was pretty small and we only looked at Malaysia, we went on to look in Southeast Asia. So this is something that has been accepted in Lancet Global Health, and we will be very happy to share the findings once it's published by next week. We should have this paper out. So I'll be very happy to share this later. And so I've said what we have done over the past 10 years and where are we now and how do we move forward. So this is where I would like to share what are we doing now, and this is something that we are looking forward for collaboration. So we are really looking at financial navigation because we know that there is a disconnect between patients and financial resources, and we are aiming to match patients to the resources that they need. So this is something that we are looking at, and this is the conceptual framework that we have. On one hand, we have the patient and households, and on the other hand, we have a whole list of agencies and stakeholders who may be able to help patients, not only in terms of waiving medical fees, but also looking at things like how do we help patients manage their assets and debts, how are they going to plan their financial planning in the coming years, and how can they optimize their insurance and so on. So I'm not going to read what are the things that we have at our end, but we have started engaging the stakeholders to start the ball rolling. So with that, we aim to develop and evaluate a financial navigation program for people living with cancer in a setting like Malaysia, where there's actually a dual public-private healthcare system. So that only means that when we plan our navigation, we have to be sure that we cover those who are in the private system as well as in the public system. So there are 3 phases that we envision where we will co-design a financial navigation program together with the stakeholders, including patients, and then implement that financial navigation program, and following that, evaluate the short-term impact and sustainability of such a program. So this is something that we are planning and looking forward for finance, for funding, as well as for collaboration. And the other thing that we are looking at is looking at traditional and complementary medicine. Malaysia has got a traditional and complementary medicine division under its Ministry of Health, meaning that traditional and complementary services are regulated. But the problem that we have is, for instance, the Ministry of Health, only 15 of our 144 hospitals are integrated hospitals where traditional and complementary medicine is offered in the conventional healthcare system. And looking back out with our experiences from the action study and the knowledge that we gained from our qualitative inquiries, we feel that it is only just that we provide evidence-based complementary therapies through conventional healthcare, which will be beneficial for patients. They can come to us and they can stay with us and continue their treatment without having to spend so much. And that is what we are working. And therefore, we are building evidence to facilitate integration of traditional and complementary medicine into oncology services. So here we are going on a mixed method study where we are going to do some qualitative inquiries followed by a survey and also a Delphi to come up with strategies to integrate, to have fasten the integration of ECM into oncology services in public and private hospitals in Malaysia. So with that, that is what we are up to, and we are really looking forward for collaborations or even conversations. That'll be fantastic. Thank you. So with that, I'll stop sharing.
Yeah, thank you. Thank you very much, Nirmala. I mean, it's such a large study. I mean, the sample size is really large and fascinating findings. And we have a couple of questions, so I'm going to read through that to to begin our discussion on the research that you presented. So the first question goes, for the families that had a death, shouldn't their financial catastrophe be analyzed? I wonder if that would change the data. What are your thoughts?
That is something that we were asked many, many times. Yes, it is possible that someone incurred financial catastrophe, the families, and then there was a death and we counted them as death. But what it would mean is it would change the data, but it would not change the interpretation, because if we assume that patients had catastrophic expenditures and passed off, then it would only inflate our findings. I mean, we would have higher risk of catastrophic expenditures. So I think our findings are conservative for that reason. Yeah.
Okay. Thank you for that. We have the second question here. In the predictors of financial catastrophe, getting chemotherapy increased the risk. Did you find that surgery, radiation, endocrine therapy did not make as much of a difference? In addition, were you able to separate cancer-specific mortality from all-cause mortality? And they have a third part, in addition to the contribution of comorbidities such as hypertension and diabetes. So I can read the first part again. In the predictors of financial catastrophe, getting chemo increased the risk. Did you find surgery, radiation, endocrine therapy, did they make any difference?
We did not find any difference when we looked at surgery, radiation, endocrine therapy. And because in the interest of space, I did not show the other results, which were not significant. But if you go and look at the paper, you can get more information. So they were not associated with financial catastrophe. And we only looked at overall mortality. We did not look at cancer-specific mortality. Our death registries are not fantastic. So it is not easy to look at cancer-specific mortality. And for that reason, we didn't. And when looking at comorbidities, we did not have, for instance, we did not look at Charlson's comorbidity score, but we did have data on comorbidity, and it was not associated. So this is again something that you can take a look at the actual paper, and you will find more information on that. Yeah.
Okay, thank you for that. I was also wondering, you have followed the patients for a year. I wondered if you can comment on, post-treatment surveillance protocols in public versus private hospitals in Malaysia specifically, but if you want to make any comments or observations from other countries, is that something that routinely happens? If so, how? If not, what are your thoughts on that?
When you were talking about surveillance, are you alluding to surveillance in terms of disease surveillance or just general surveillance on overall well-being? What are you alluding to?
Both, to monitor for post, side effects, post-treatment sequelae, for instance.
Okay.
Once they leave the hospital setting, what happens and what kind of engagement is there?
I think most of the time in our settings, the problem is that the surveillance for disease just goes on and on. So much so that I think this is my personal point of view, that I think that's a problem, because a lot of patients over long term just keep on staying within the oncology system and do not go back to the primary care physicians and so on. So on one side, you have a lot prolonged surveillance for disease, but in terms of prolonged surveillance for well-being, return to work, and survivorship phase, that's very little at the moment. Not only in Malaysia, I believe it's the same in Southeast Asia and many other low and middle income countries. A lot of focus on disease rather than on the person as a whole.
Right. Another question. Thank you for a great talk, Dr. Bhoo Pathy. Are there results from your work that you anticipate are generalizable to most LMICs and others that you think are quite specific to the Southeast Asian and a Malaysian context?
I believe so. In fact, I don't think this is something that we can only generalize to low and middle income countries, but also in higher income countries. And why I'm saying that is because we looked at countries, when we looked at Southeast Asia, we had countries with universal health coverage. So, I mean, there are limitations in terms of what you mean by what is covered. But nonetheless, we brought out important points like non-medical costs were important. And we also brought out that traditional and complementary medicine leads to excessive out-of-pocket expenditures. And these are something that we can apply also to other low and middle income countries where there is a preponderance for use of complementary medicine, for instance. And likewise, when we look at high income countries, you also know that complementary medicine is increasingly becoming popular. And apart from that, when we have universal health coverage, it's assumed that all is well. And we know that it's not, and non-medical costs are important. So this is something that I think is something that we can reflect everywhere. That's why I think Southeast Asia is a good place to look at, because we have varying levels. Of course, it would have been fantastic if we had Singapore included, but we didn't. But nonetheless, I think it's pretty much something that can be generalized elsewhere.
Just going back to your note about complementary medicine. So you said that about 14 or so hospitals out of 100 some in the country are integrated, right? So I just wondered, what are your thoughts on, because obviously the patients are seeking that type of treatment out. Are there any discussions about involving those practitioners in some way in the care pathway that can then, bring them early perhaps to the hospitals? Any notes or thoughts on that?
I think that is something that the traditional and complementary medicine division, for instance, in our Ministry of Health is interested to. But the division was developed in 2004, and we only had our act up in 2016. So we have a complementary medicine act in Malaysia. And they are trying to regulate everyone. So for time being, the only ones that they can regulate is whatever services that's provided under the auspices of Ministry of Health. But they are looking forward. But there's a lot of evidence and knowledge gap. And that's what we are trying to fill up. So I think there's a lot to be done in order to make services accessible and also to regulate the diverse practitioners out there. Yeah.
All right. So there's another question. I'm not reading the names of the people. I should have, and I'll just point to that later. But here, the question is from a cohort study in Baltimore. We saw a surprising proportion of women reporting routine supplement use. That is, these are non-cancer patients. Do you know the global literature on expenditure on supplements relative to the evidence on health impact? Because this is pretty grave. I don't, and I wonder if it is well studied, or we are just generally underestimating the prevalence of this behavior.
Okay, I believe there are already some studies looking at supplements and health impact. I mean, when we are looking at survival and lack of benefit. So they didn't really show that supplements are associated with higher mortality, but there are evidence that there is no difference. It doesn't provide a benefit. But what we have in relation to cancer is very limited. So a lot of it is in the general patient population, which means it's a mix. But I'm not an expert in traditional and complementary medicine, and the only reason that I got very interested is because of what throughout the journey, what we've experienced. So I might be, I'm missing out something. So I have to say that, yeah.
No, thank you for that. There's another question here. Could you please elaborate on complementary medicine expenditures being higher than normal medication expenditures?
I think that was not what I intended to present, because it was not higher than normal medication expenditures. I think when you mean normal is conventional medical care, what we said was complementary medicine. The expenditures on complementary medicine constituted 30% or 35% of the total health expenditures. So right. Families were making out-of-pocket expenditures for hospital visits and so on. And out of that, all that expenditures they were making, 35% or 1/3 was actually spent for complementary medicine. 50%. So it's a proportion, not compared to, yeah.
Thank you for clarifying that. Yeah, I don't see any other questions. There's one more coming up. How easy was it to keep a cost diary?
Not easy at all. That's why I was alluding to, when we had close to 10,000 patients when we recruited in the beginning, everyone was so proud. But towards the end, we lost a lot of patients. Not only, I think the cost diary itself was very overwhelming for a lot of them because they had to jot down. So
Right.
we had to settle with, people not putting exact details, but amounts. And that was the reason why towards the end, we were unable to exactly itemize, expenditures. We were only broadly, because we actually gave them broad domains, like, is it a clinical related expenditure, and we asked them to write it. So it was not easy, and that's the reason why we even built a 3-month follow-up to make sure that people don't lose their cost diaries. And so that was the point where we actually sit and review those diaries. So it's not easy. That's why if anyone want to, do a similar study, it's going to be very, very resource intensive. This was a very resource intensive study. Yeah.
Right. And is there any way to collect cost diaries effectively from low literacy patients? That's a question Dr. Gopal's asking as well.
Again, I think I don't have the expertise to comment on that, but I would assume that, now because we have all of digitalization, and, is there a way that people can, like, instead of having to write it down, can they, use other ways to record their expenditures, photographs, and, something like that. They do that for food intake. So why
Right.
not expenditure? I think that might be something that we can think about.
Yeah. All right, I think we'll have to leave it there, Nirmala. It was just fascinating to hear the work and the planned projects in the future. Thank you for your time. We hope that we can, this will be recorded, obviously. If there are specific questions we get, we hope we can share your email with colleagues here.
Thank you so much, Sudha.
Yeah, no, absolutely. We just wanted to let people know that there's a couple events to draw your attention to. Our 10th annual symposium on global cancer research, which is a pre-conference event in collaboration with the Consortium of Universities in Global Health meeting, is on March 23rd and 24th, and where we will be talking about new models for global cancer research, training, and control. And as we mentioned, on top of the art, this is a series. So we will also be having our next speaker in April. And that information will come up in the next slide. And that's Dr. Nelly Mugo from Kenya. So we look forward to your participation at both these events. And thank you for your time. Thank you, Dr. Bhoo Pathy, for your time today, and look forward to working with you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.